Welcome to the My Health Record webinar. My name is Sharon and I'm from the RACGP, and I'll be assisting you with any technical difficulties today. As you may be new to webinars, we thought we'd take a few moments to help you feel comfortable with the learning platform and your options to communicate with us. Throughout the webinar, we will refer to your control panel. If you're using a computer to participate and you are unable to see a pale blue and grey screen like the one in the picture, look for the red arrow in a small box on the top to the right of your screen and click on it. The control panel should open. The control panel provides you with tools to select if you're using a microphone, speakers or phone to listen in, and also to place a question. During the webinar, all participants have been set to mute from our end. This ensures that any background noise is eliminated, enabling us to stick to the time schedule. If you have any questions throughout the webinar, please send them through the question box on the blue-grey panel. If you have a question or comment for us, please send it through the question pane or the chat pane. We will have opportunities for questions throughout today's session. We'd just like to do a quick test. Does anyone like to type in where they are in the question pane, and we can see where you're coming from and listening in today? Okay, so we've got Wongan Hills, Perth, WA. That's great. Does anyone want to put else in? We've got some few people letting us know Greenwood. Great, some local people. Thank you very much. At the end of the webinar, just to let you know as well, we will be sending through a questionnaire and evaluations form that will help us gain feedback and improve our education delivery. The survey is also a requirement for you to earn your QI and CPD points. So I'll now hand over to the team and we will now start the webinar.
Thank you. Thanks very much, Sonia. Firstly, we'd like to acknowledge the traditional custodians of the land that we're meeting on today, the Whadjuk people. We wish to acknowledge and respect their continuing culture and the contributions they make to the life of this city and this region. Thank you all for joining us today for our GP webinar about My Health Record. My name is Chris Kane and I'm the General Manager for Strategy and Policy with the WA Primary Health Alliance. This is the first of what I'm sure will be many events in the lead up to the My Health Record system going opt-out in 2018. There's a very clear need for improved access to patient information now more than ever, and this is what the My Health Record is designed to do. It may have had a rough beginning, but the WA Primary Health Alliance is a proud supporter of My Health Record and very pleased that the COAG Council recently endorsed the system to move to an opt-out model of registration. As a result, it is hoped that by the end of 2018, nearly every Australian will have a My Health Record and every registered healthcare provider in Australia will be able to access the information within them to inform care for their patients. Today's presentations are designed to give you a greater understanding of how the My Health Record system can benefit every Australian and how digital health can further improve patient care. We have presentations from two expert clinicians to talk to you today, as well as a Q&A opportunity with the speakers at the end of the webinar. Simply ask your question at any time throughout the presentation by using the side menu and we will come to you at the end. So I'd like to introduce our speakers, Dr. Monica Trujillo, who is the Executive General Manager, Clinical and Consumer Engagement and Clinical Governance, and Chief Clinical Information Officer for the Australian Digital Health Agency, and Dr. Steve Hambleton, a general practitioner working in Brisbane and a former state and later federal president of the AMA. Steve served on the AMA Council of General Practice for more than 15 years and is a leading clinician within the Digital Health Agency. So thank you both, and over to you.
My name is Monica Trujillo, as mentioned earlier. What I'll do in my section is briefly introduce the agency, how we set up the programs, what we've done this year, briefly talk about the National Digital Health Strategy, and then we do a deeper dive into My Health Record. We do want to have as an aim sort of a review of what we're calling the new My Health Record, which we've worked really hard on to actually have some valuable clinical content in there. So we'll be covering that as well. Please, we'll do a little stop midway and check for questions, and then I will hand over to Steve. So So to introduce the Australian Digital Health Agency, we'll refer it to as the agency. We're not allowed to use the acronym of ADHA, it's the Australian Day Hospital Association. So you'll hear the agency, and this is how we ended up with this title as well. But we really were created a year ago after a review that was done by Richard Roy, Steve Hambleton, and Mark Waldock.
Andrew Waldock.
Andrew Waldock.
Chief CIO or CIO of Australia Post.
Of Australia Post at the time. We're really you know, that review gave birth to a lot of the recommendations that gave birth to the agency. So the agency in itself was created to really, one, give consumers more control of their health and care through access to information and digital platforms, to connect and empower the healthcare professionals who serve our consumers and carers, and then to support the industry that supports the healthcare professionals as such. So the agency in itself is an independent agency. We have our own board, but we do report to the Minister that way. One key factor as well is the agency from a year ago is now the new system operator for the My Health Record, and we took over the operations of My Health Record since the 1st of July 2016. So what have we been doing since we opened? Since we've been opened, we've obviously had the My Health Record, and we'll go into that in a little while. We've been working on part of our rule that the agency was established. We've been working on the National Digital Health Strategy. So the development of the new National Digital Health Strategy has been a long journey for us. We started an open consultation. We wanted a co-production type approach to the National Digital Health Strategy, and we wanted to hear from all aspects of the consumers, clinician, and the industry on what they wanted and aspired to have in the National Digital Health Strategy. So we opened consultation in November last year, closed in the end of January, and we now went through all the different processes of assurance, government approvals, and we were very happy to release that. I think it was welcomed last week as well, and that is on our website. If anyone wants to particularly have a read on that, it's actually on our website as such, which is at the bottom of that slide, digitalhealth.gov.au. The other program that has been going this year, we heard loud and clear the clinicians wanted us to focus on secure messaging, and the college in particular wanted us to focus on secure messaging and tackling that big elephant to resolve. So we have created a secure messaging program, which has now released announced two sites that will go and be test beds for different use cases as well. And that again is in our website, or we're happy to send more information as well. Then the other section that we've been working on very hard is on the interoperability side, and for that we actually now are about to launch some of the consultations of what does that mean for us, for the Australian environment, and again have been working very closely with the college to achieve what does the actual environment need in Australia. And the other bit that we've been working is to actually support the new models of care and innovation in Australia. So we're not here to be a super big central authority. We're here to support the new models of care and work with programs that are already established and moving forward. So some members might have seen the National Children's Collaborative for Informatics announced, where all the states and jurisdictions worked on top priorities in the child informatics area as see what was the top priorities, and those will be announced shortly as well. Big roundtables, big consultations, but that's been a good initiative to work on as well. Shortly we'll be announcing telehealth and obviously the other healthcare priorities, which are mental health and aged care as well. Now, a deeper dive on what we've been doing with clinical programs. So with the way we set up our programs, and my role in charge of having the programs deliver products that are safe, that are useful, and as well that actually provide value. So we've twisted the programs apart from being an IT project to being a clinical program. So as such, we have a medicine safety program, pathology program, diagnostic imaging, and the other two usability improvements and operational requirements are really to support the delivery of the three at the top there. The way that is set is we have a clinical chair, so Steve Hambleton is the clinical chair of all our clinical programs, and we have a consumer co-chair, and the Australian Safety and Quality Commission assists with that. And with the diagnostic imaging, we have the College of Radiologists as a co-chair as well. It's a representative group, that is the steering committees. so the college has representative members in all of those committees, and as such they all have technical working groups for some of the initiatives as well. So with medicines, the steering group worked very hard this year, and we'll show you later, on that one single view of medicines. That was a top priority for all the members of the steering group, and we delivered that this year. And for those that don't know, we'll be able to show that later on. That is a critical requirement for all the clinical areas, and that one's one that we delivered and we're quite proud of. There's always room for improvement, but at least it's a really good start. For pathology, we've worked this year on moving across from public pathology results to go into the My Health record, and we did announce that the two lead sites for private pathology. Those two lead sites will have an evaluation framework, and they have a technical working group. The RSCGP actually chairs the technical working group to make sure that workflows and that consent process and everything is evaluated and works well before we actually go and move any further. So diagnostic imaging, similar model, is around uploading the results of diagnostic imaging reports. We have heard loudly and clearly from the committee that they want access to images, but at this particular time we've delivered access to results, but we're moving towards access to images as well. Heard from our consumers that they needed some usability improvements in the access to My Health record, and that's been delivered this year as well, and really focusing on what the requirements are to make sure that the My Health record is sustainable as well. That's been the rest of what we've worked this year. So for the My Health record at the moment, and Steve will go into the details as well, for those that I wanted to go on the stats, we now have more than 5 million consumers registered as well, and WA, there, if people can see the slide, actually is at 17% of consumers registered. We actually have continued to connect more and more facilities. So in WA, we have the private systems, we have HealthScope, St John of God, and Ramsay connected to My Health record now, and obviously the public hospitals are connected and working to make sure that enough information that is valuable starts going into the My Health record. And for that, you will see the right side of the screen. It shows you the usage and who's uploading and what type of documents are being entered into My Health record. So what is in My Health record? My Health record these days looks a little different from what it used to be. So we have information flowing on from obviously general practices, from hospitals for discharge summary. We have some information from specialists, in particular pockets around specialist letters, path and diagnostic imaging as mentioned earlier as well. With pharmacy, we've done a specific strategy around increasing the number of prescription dispense records. So some of you might have seen the announcement last week where we're working with all the pharmacy software providers to make them conformant and be able to upload dispense. So that actually is moved and progressed quite fast this year. So you'll be able to see more and more medicines information in My Health record. Significantly, as Chris mentioned, the government heard very loud and clear that unless we made it an opt-out approach from the report that was done by Steve and Richard earlier on, we wouldn't be able to actually access all the big benefits of what My Health record can deliver. So this year, a decision was made by government to expand the My Health record program to all Australians unless they choose not to have one. So by May next year, every Australian will have a My Health record unless they choose not to have one. In order to get there, we have a lot of work to do with our consumers, with our clinical community, with the industry to make sure that we have, one, meaningful information in there, and that's what we've been working on this year. Two, that access is not obstructed, and three, that it supports clinical practice. So, and people are aware of how to opt out, how to direct for questions, and how to actually find more information about what this actually means. So we'll move on to My Health record soon. I just wanted to share the National Digital Health Strategy, what people told us. they wanted in the National Digital Health Strategy, and really was no surprise. It was around having the information to make the right healthcare choices, to help the clinicians communicate to each other, to create an environment that was safe and they could trust as well, and to make sure that all of this becomes into personalised care as well. So those were the 4 big themes that came through the strategy in the consultation. And what does this mean for Australia? This means that there were 7 priority areas called out for delivery from 2019 till 2022, and they're all outlined there for you into 7 priority areas, and then on the left you'll see what the programs to support them are. So these are the strategy areas. The next step will be what we've called the framework for action, which means, well, who's doing what, and how we checking that it works, what is the benefits model, what's the evaluation. So that's what we are working on now, and we'll aim to have something by the end of October. Make sure there are some initiatives that the agency will lead, there's some initiatives that the agency will support, and there are some initiatives that we will partner with other areas of the healthcare system. So what we're looking at is a future that supports people through all the different aspects of their life, from pre-birth all the way to end of life, to be able to have enough information across all the different areas of healthcare so they can support stay for their health and care. So this is an infographic that sort of summarises that. I'll encourage you to go through it. I won't go through all it now, but it's quite an interesting one as well to go in detail. So with that, I will stop for a minute, and we've got a couple of questions.
We have had a couple of questions, and one of the questions is about security, and in fact I'll probably deal with that as I bounce through the slides. But we'll pause for a moment, so those online, if you'd like to ask Monica a question about up to now, and I will deal with that security question in a moment.
Oh, there's an allied health sector question. Yes, that is a really good question. Working really hard with the allied health sector, and particularly with their peak bodies, to see how we can support them in not only the provider portal, as you quite rightly say, Jane, is a view-only solution, but we're now working with the industries to give them solutions that are fit for purpose and not as expensive. There's a couple of solutions that have come up, and we're working really hard and tight with them to support allied health, not only viewing but as well uploading. That's a really good question. Will there be a wizard to assist people in opting out? Oh, that's a really good question, because part of the Release 8 improvements that we did for consumers, there is a wizard now when people go in and go in for the first time into My Health Record. So there is a wizard now with the new release that was done. So Graham, that answers that question. So that there is a wizard with that release, but there is also what we heard from the opt-out sites is that consumers actually wanted to talk to people to go through what were the steps to opt out, what were the benefits. So obviously there's a big program of work to make sure that we have all those avenues covered when they want to talk to someone, when they want to walk into somewhere to get their questions, when they want to follow up any further questions as well. So.
And broadly, we want to make it, for those that want to opt out, we obviously want to make it easy to do so.
Yes.
And in fact, in the trial sites, as we all know, less than 2% of people opted out. And they did do an intensive community-based education campaign that was multi-channel to try and engage everyone in the area, so they understood that they were part of the process and they would have a record unless they chose to not have one.
Mm-hmm.
And that's the plan more broadly next year in the expansion program, to make sure all of Australians are aware that a record will be created for them unless they choose to not have one.
That's right, Steve. And what we've seen now further along with the opt-out sites, some of those 2% of people are going back, opting back into My Health Record now, that they know a little bit more about it.
All right. Well, we'll carry on. I'll try and go through these so we can get to questions. We've got a fair bit of time, thankfully. Look, I think I'd just like to always make the point that why are we doing this? And this is a good slide that talks about that. When data's stagnant, when it's stored in the envelopes at the back of our surgeries in our filing cabinets. You can't analyse it, compare and contrast it. You can't draw information from it. You can't really do population health, which is really our role in primary care. And it's not available to anybody else except for that person at that period of time. So I guess that's the background. What's happening in Australia? Well, the reality, this is the reality, every 2 or 3 minutes there's an admission to hospital in this country for medication misadventure. And we as GPs, it's our patients that are being admitted to hospital. For various reasons, whether it be a drug that's incompatible with something they're taking, people being given drugs that are allergic to, people who've had reactions to drugs in the past, just the normal incompatibilities that we know about. But 230,000 admissions for medication errors. If we could take them away, we'd save $1.2 billion overnight. And if we just shared, forget about everything else, the current medication list in our allergies, we'd make a substantial reduction in those. And they're my patients, they're your patients, they're our patients that are suffering. Pathology and radiology, somewhere between 14 and 17% of tests are duplicated. You guys do a test, they turn up in emergency, either haven't got it with them. It's much easier to do that CT scan again, much easier to order the tests again. Make a referral to a specialist. Patient's forgotten to take the paper referral, much easier to re-request all of that stuff than try and find which pathology company they've gone to. Our nurses in general practice are spending hours. We're spending hours. When a patient says to me they've gone somewhere and I go, oh my goodness, how am I going to find that piece of information? We want to cut down that time. The other issue is that there's data volumes are exploding, and I'm sure one of you is going to ask the question, well, there's going to be so much data, how can we possibly read it all, get access to it all? And that's where we need the smarts, and that's where I'll come back to in a minute about the release 8 of the My Health Record. The first time we're using smart filtering technology to present to us something that's clinically useful. That was a critical outcome of the Medicine Safety Working Group. I'll talk about that in a minute. And just a reflection, by 2020, 1.7 megabytes of new information will be created every second for every human being on the planet. We can't do this alone. We need, and I don't think we're going to be replaced by artificial intelligence, so don't change careers yet. But we do need this to help us do our job for our patient in front of us. Look, we've talked about some of this. I'll flick through some of these. Obviously, the slide deck will be available later. It is a health summary. It's not the whole record. It's key pieces of information that can be shared securely online with the permission of the individual and their healthcare providers. It's a national system, so if your patients end up in Adelaide, if they end up in Kununurra, if they end up in Albany, their records will be available. It's personally controlled. We actually want the patients to get engaged in their care, to understand and see the information that's in their record and correct it when it needs correcting. I've had a 73-year-old tell me that their health summary needed correcting, which was fantastic, which we did. It needs to be accessible, needs to be there at emergency departments when they need to see it. We need to get access to meaningful information, meaningful clinical information to help us. And right now, you could quite argue with 17% of the population in WA signed up and only a proportion of those with meaningful clinical information. We're not at the tipping point yet. That's the reason for the expansion program. We've seen this slide before today. That's the source of the information. And we've heard the message loud and clear that our private community specialists, we need to assist them to engage, and we need to look at what software they're using so they can get in and provide a contribution to that information. What else is in there? There's Medicare claims history. I've said it a few times. I mean, I don't care if they've had a colonoscopy. I want the result. The pharmaceutical data, the pharmaceutical benefits information, it only forms part of the record. It's not meaningful to me for my patients. That clinical information is what I'm looking for. But organ donor status is an important one. Advanced care plans can be now uploaded by the patient to their record, so that they're not locked in the safe when they turn up in emergency, and we know what the person's wishes were. And patients can write their own notes and put emergency contact details in there in their record. This is what it looks like in your software, and I haven't got all of the major softwares, but I can refer you to the Digital Health website, where you can get into a test bed and look at how your software operates. You can dial in, get a password. It works exactly like what's on your desktop. If you want to get in the sandpit and have a go, then you certainly can. I'd certainly recommend it, rather than having a patient sitting next to you while you're moving around the screen. But it's your software. The simulation works quite well, quite close to real time. This is how it works in Medical Director, creating an eHealth or a shared health summary. Information is extracted from your information system, dumped into the record. So the reminder there is if we've got quality data in our systems, you'll get a quality shared health summary, which will be beneficial to the patient, might reduce some of that medication misadventure. It's not when we're writing a referral, it's actually when they're engaging with the system. When we haven't written a referral, they'll get the best benefit. And of course, their immunisations are all logged in there. That's what a shared health summary looks like when you look at it with your clinical information system. That's what the hospital will look at when they see the patient. That's what the specialist can look at. It depends on their clinical package, but that's the way it's set up. And it's adverse events, reactions, medications, medical history, and their immunisation data is what a health summary looks like. Now, when you're in the hospital and you're looking at the NACS users can get access to that data. So when they look at a record, for example, we've just come from Fiona Stanley, when this little symbol comes up, I don't know if you can see my mouse moving, but where the big blue arrow is, if that symbol comes up, the patient has a record, they can go into it and actually see what the information that's in there. Yeah, that's the same system they use for discharge summaries that sends us information about patients outbound. When you're viewing documents, again, this is through the hospital systems. They can see a list of the types of documents. They can look at discharge summaries that have been generated elsewhere. They can look at shared health summaries that come from general practice. They can look at event summaries as well. When they upload when they actually upload a discharge summary to you, if the patient has a My Health record, a copy of that goes to their My Health record. So if you're not the primary clinician, you can look at that. So if you're a specialist, for example, non-GP specialist, and the patient has a My Health record, you can actually go in and look at their discharge summary, even though it wasn't sent to you directly. Now, this is the key for all clinicians. It's access to information you might not have already received directly. So remember that information search time. We want to decrease it. We want to help our nurses minimise the search time so we can get information more quickly. And what's in it for us? Well, we do need meaningful clinical data there so we can read it, not just upload it. And we are certainly able to provide a huge amount of meaningful clinical information for our patients, but also it will become a source of useful clinical information for us to view as well. We've got to remember all of the healthcare teams, so our pharmacist colleagues, our allied health professionals, all of this information with the patient's permission will be available.
How can GP view health records?
We've got a question coming in.
I can actually go into My Health records, this is the bottom one.
Okay. How can GPs view health records? On your clinical information system, there'll be either a red box saying My Health record or a green box saying My Health record. If the patient has a My Health record, it'll show up green. If you click on it, you'll get a list of the information that's on there. And you can then filter that by document type. And I'll come in and show you a little bit more about that in a moment. Privacy, and this relates to the first question. That the first question was that given that this year's already seen news of Australia's hacked Medicare details being offered for sale on the dark web, what are we doing? Well, privacy is really important. I'll roll the clock back a bit. Australia's Medicare information wasn't hacked at all. It was someone with legitimate access to the system that actually decided to misuse the system. So it was criminal behaviour. It wasn't actually a hack, so to speak. And in terms of safety and security, the system is set up to be very, very safe. And I think in either this slide or the next one, we talk about bank-level security. And I always say it's better than the bank. It has to be better than the bank, because how many people know someone who's had their bank account details misused? Security levels are very high. To get into the system, you need to have a clinical information system that's set up properly. And it's pretty complicated to do that. Yes, we want to simplify it, but it needs to be a concordant system that's set up properly with security keys. Certainly you can use the patients can look at their own information, but they go through a stringent process of identifying themselves. There is a portal that registered health professionals can get into, but they also need to thoroughly identify themselves. And when someone looks at the record, basically we know who's looking at the record and how long they spent there, and we can measure all that, and the agency certainly does. Patients can control who sees the record. They can set up filters so you can see none of the record, all of the record. They can only make certain documents only available with the passcode that they provide, and certainly patients have access to who's looked at their record and who's interacted with it. I've got my health record, and I've set up a SMS reminder that sends me a text message if anybody looks at my record. Actually, one day I did get an SMS message, but I looked at my own record. And I think that's really important to give people confidence that we're very serious about security. It's a layered security model that uses the government's MyGov for patients to get into their own records, but we do have a cybersecurity centre which monitors for unusual behaviour, very strong encryption and firewalls. Criminal behaviour, clearly we can't control, but we set up systems to make sure we detect it if there's criminal behaviour very early, and we know where it's come from and we can do something about it. We talked about patient control, SMS alerts, all accesses are logged, and all of that's reviewed. I did mention that you can have a record that's got meaningful clinical content that no one can see without your permission, but if that patient ends up in emergency, or you decide that you need to see that information if they're unable to give permission, you can break glass and look at that record and gain meaningful use, and of course that's logged. We're mobile ready. This is my health record using an app called Healthy, which is written by a company called Chamonix in South Australia. And so you can see on the record that I can see myself. I can see my daughter, who's actually 16. And I'm sure her name will disappear from that fairly soon as she takes control of her record. I can see my father as well, and that's already come in handy when my father was interstate and needed to see someone, and I was able to get into his record and look at his shared health summary. So there's my subset of my this year's my vaccine this year for flu. So I hope all of our listeners are all vaccinated against influenza. Certainly in Queensland there's an epidemic at the moment, and it shows you where my medical practice resides. So we're mobile ready. Monica mentioned earlier that we've taken release 8 of the PCEHR is release 2 of the My Health Record, and we went out of our way to try and add some usability and changes in this release to make it easier to use, to make the information easier to access. And that's a summary of what we put there. The meds view I'll look at it in a minute. Pathology view enhancements, so I've got the search function. There's a simplified pathology view, simplified diagnostic imaging view. There's changes to the Australian Childhood Immunisation Register to make it the Australian Immunisation Register for everyone, not just for children. The consumer portal's now easier to use with that wizard to help people through first time round. So we've made some significant change there, and it's a different beast. If you haven't been to the My Health Record for a little while, go take a look at it. As I say, mobile friendly. How do we do that? Well, for medicines, the Meds View, we actually collected clinicians together. We heard the message loud and clear at the PCHR review. This needs to finish with clinical workflow. It needs to make sense. It needs to be a clinical project, not a tech project. And I think Mukesh and my colleagues from the college made that point loud and clear. So we had consumers, we had clinicians, we had advisory groups. They all actively contributed, and that co-design is the new way of doing business. So it makes sense to a clinician. What's the Meds View look like? It's a consolidated view of all of the prescription and dispense records in the My Health Record, using for the first time smart technology to put that together and present it in a clinically useful way. So it looks into and at the last discharge summary. It looks into and at the last shared health summary that you may have put up or a colleague may have put up. It looks at event summaries that might have medication into it. It might have prescribed and dispensed records, and it tries to present that in a meaningful, useful way. It's certainly visible. The patient can see it. The health snapshot tries to help them see that information, and the medicine's information is part of what they'll see. And that I'll show you a couple of snapshots of what the patient will see. I'll go on to what the profession will see in a moment. There's the provider portal. This is not what you'll see with your clinical information system. This is what you'll see if you dial in directly. And you'll look at the document preview list. Allergies and adverse events is one tab. Medicines preview is another one. Latest shared health summary, latest discharge summary. Those are the 4 columns where you might find the most useful clinical information. Remember, this is about the last 2 years of data presented in a simplified way. That's the medicines preview, but I'll move into what you'll see on your clinical information system. So if you click in with your best practice or your medical director or your genie or your medtech, this is exactly the information you'll see in the layout you'll see it in. Allergies and adverse reactions, those 4 columns are the same. Now you've got hot links within this document to take you to the source document. Medicines preview will give you a summary of what the medicines you probably will be taking, just shorten that medicines curation time dramatically. And then when you want to look at source documents, they're actually tabulated as well. And hyperlinks, as I say, work and take you directly to the source document, making it very simple, much simpler than it used to be to actually, rather than opening each individual document one at a time. We'll move on to pathology and DI, and I think we should probably then try and poll for questions. Pathology and DI, as you've heard, is part of that meaningful clinical information, and part of the value proposition for having a centralised record, so we don't do the duplication, so we get quick access to information that we need. And of course, it's only going to be useful if we actually can search it quickly and accurately, looking for information that is meaningful. And again, those are the reasons we're doing it. Certainly, we want to minimise risk to our patients. This is what it looks like inside the record. This is a patient looking at their own record, and patients will get access to this information after a 7-day delay, which is something the college recommended when this was originally set up. You know, the college's view may change, and we need to understand that. Maybe there's an option for a shorter delay for things like INR. Maybe some things won't go there at all, and clearly at the moment some things don't. Maybe the 7 days is less, but we need to consult with the profession to work out what works and what's right. Here's the patch reports, looking at the provider portal, and DI similarly, you'll be able to look at the DI. Now clearly we need to have some harmonisation of the what we call an ultrasound of an upper limb or a lower limb or upper abdomen, lower abdomen, right across the country. So when you start to share this information, you realise that national standardisation or mapping to a standard is so important. But we can't wait for that. Perfect is the enemy of good. Let's get on with sharing this information now. So and then incrementally build on it. So here's the benefits we're trying to put together. Less adverse drug events. Remember those figures. Admission every 2 to 3 minutes in Australia for medication misadventure. Huge savings. Engaging and activating the patients. A message you heard with the healthcare homes. Our patients are on their own for most of the year. If we can provide them with background information, access to good knowledge, get them checking and reviewing their own data, we can engage them in their own care and activate them. It doesn't work for everybody, but we've got a very IT savvy people coming through. We want to improve outcomes, and we need to monitor and measure that. We don't want to, we want to make sure that we get the outcomes we need. We want to make sure we reduce time gathering information, and all of us on the phone on this conference realise how much time it takes when the patient says they've just been discharged from hospital. You have no clue about their medication list, and you've got to try and find it. We want to avoid duplication of services, so important. I might just reflect on the reason, one of the big drivers of going to opt-out, and we observed a very good comprehensive system in the Northern Territory, which is the My EHR and it was, if you look at the dates, it took probably the best part of 5 years on an opt-in to get to 50% of the population. Yep. So it took the best part of 5 years, very little use of the My Health Record, and you might echo that we have very little use of the My Health Record today. But once we got past 50% of the population, a dramatic increase in use, an accelerating use of the record. And the lines on this graph talk about who generated the document and who looked at the document. Putting information on the My Health Record isn't the solution we're looking for. It's actually using the information that's on the record for the patient's clinical benefit. So it's reads, not writes, we should be measuring. And this is what this document measures, reads and writes. Who wrote it, who read it. And when we went to the Northern Territory and talked about, the future with doctors who are using the system, basically they said, please don't turn it off. In fact, if you turn it off, we'll pay for it out of our own pocket because we find this so useful. Now, you wouldn't describe the My Health Record system today in that way, but it's interesting when we, for example, all of us use computers on our desktops. If someone said, we're taking your computer away, I think all of us would say, I cannot practice medicine without my computer system. And I know it's a high ideal and high goal, but we've really got to provide a simple system that helps us do our job better, that we find beneficial and helpful. I think that's the target. Now we'll be looking for questions from the group because we want to make sure we get plenty of time.
Can we check that we answer the GP's view health records? I think we did cover that question.
Yes, I think so. The GPs can actually use their clinical information systems to do that. But if you're on a house call and you want to do it, we need to get you set up with the provider portal, which you can look at on your portable computer. So there is a second way of doing it that you can get access. The question about data quality, look, I think this is a team approach. We know, all of us on the teleconference realise that it's quality of information in our systems dictates what we can extract from our systems. I know the college is working hard on quality improvement of data in our clinical systems. It means when we write a referral to our colleagues outside of our practice, we provide a quality referral. When we upload health summaries, you get a quality summary. It's likely to help the patient get a better outcome. So data quality, very, very important. Lots of documents are missing data, and I agree with allergies. We need to work with our hospitals, use our PHNs and hospital connections to actually make that mutually beneficial. So our responsibility as GPs is to provide accurate information on the inbound side, but equally we need accurate information on outbound and why the medication was stopped, what they went in with, what they came out with. There's a basic data set that we need to be able to pick up that transfer of care from the inpatient sector to outpatients. We should ditch the discharge summary word, and we should talk about transfers of care. I think if we think about it in that way, one professional handover is what we need. Look, I think that's a really good question. The last question on the list, and so go ahead with your typing out there. There is a significant proportion of the population that's not computer literate, and they can't set up filters, but we need to help them with that. They need to understand about what they are able to do and what they can and can't do, whether they want to be involved. They need to understand the pros and cons of the system. And I must say, in my own practice, when I talk to patients about would you like a My Health Record, I have had a few people say, well, no, I don't want one. Fine, that's fine. But the vast majority either think we're already doing it or say that's a great idea. Let's get on with it. And it's very simple, as you probably realise, those who've done assisted sign-on in general practice to get people signed up if they wish to do that consent process. But it's many of those not so computer literate people that are the biggest beneficiaries of this information sharing. So our senior citizens in aged care homes, our chronic and complex disease sufferers, people of non-English speaking backgrounds where they may have some difficulty engaging. We will have multi-language information coming out to assist those people with the decision. But we do need to put a balanced scorecard on the table about the benefits and the risks to make sure that they're aware. And I must say I've had the vast majority of people sign up with no limitations of access to the data. When you explain, it's only registered health professionals that can get access to the data. They need to have business in the record. You can't look at someone's record that you don't have a reason to be in. And if you do look in that record, it's tracked, and you know, there are severe penalties for looking at people's information that you shouldn't be looking at. And you can't get into, well, you couldn't, none of you people could get into my record. You need information about me to get into my record. And if you did, I'd get a SMS message, and I would know that you were in there. In terms of the number of people who set up controls on their records, it's the vast minority. Most of the records are actually standing consent. The number of people who've deleted records from their record is a fraction of 1%. Clinicians often ask, you know, what if there's information missing? What if the patient's taken something away? Well, our experience today with 20% of the population with a My Health record, and yes, not all of those are using it, but out of all of those people using the records, a fraction of 1% of records have been removed or hidden from view. And in reality, probably a fair percentage of those were records that were hidden in the training process to show people that you could hide records if you wanted to. So provided we talk to our patients about the sorts of information that go up, and in my own case, it's really a reflection of the referral form that I provide my patients with. Demographics, allergies, current medications, past medical history. That's my shared health summary.
Asking about how a GP can register.
For a GP, yes. Look, if you get onto the digital health website, you'll actually, there it is, www.digitalhealth.gov.au. There is a subset of that helps you guide your connection. We've certainly heard the message loud and clear that it's complicated to do so. There are checklists that you check off, and you can work through them one at a time. All registered health professionals can get access to the provider portal. It's a little bit complicated, but again, we're trying to make that less complicated. But there's a stepwise process that you go through. And if that doesn't help, if that doesn't work, then there's a helpline.
And we also have support with our PHNs as delivery partners when we're working through the program around practice support. And if there's a little bit more needed, we can actually tailor that support as well. So I don't know if you wanted to comment around that, Chris.
Yeah, so certainly with our primary health liaison officers who are out visiting practices, we do have you know, considerable expertise and support that is available through the PHN staff that work directly with practices, and we've also got a digital health officer who works from our office in Rivervale, who engages very regularly with the digital health agency to ensure that we've got the most up-to-date information to be able to provide support to the practices across WA.
The two questions there about from one from Stacey with the new opt-in ruling. Would this indicate that we as GPs no longer need to get the patient's consent whilst in the consultation to another healthcare provider? Therefore, if you're phoned by the hospital for an updated medication chart, can I send this as a summary upload? The answer is absolutely. And today, without all this information, if a hospital rang you and said, can you send me a health summary of your patient, which is in my hospital, then you have implied consent from your patient already. Within the My Health record system, there is standing consent for communication and access to the My Health record for both parties. Standing consent for the GP to upload when the patient's not in front of them, and standing consent for the hospital to download when the patient's not in front of them, provided that's for the patient's health care. So they're both working with the patient's health care. And
with the new initiatives and new program, the hospital should have access anyway to that information up to date. So there'll be less and less of those phone calls chasing you as GPs for more information, given that they can access that live data.
And I might say the My Health Record is not meant to be a communication tool, as in I'll upload now and you can look at it and download. We would say secure messaging is that one-to-one tool. This is one-to-many. By default, it means that they can use it for communication, but that's not the primary aim. Primary aim is a data resource that's available. The next question is the problem is when elderly patients want a PCHR or My Health Record, but they don't have a computer. Well, they don't necessarily need to have a computer. Some of them have got smartphones, and I must say I talk to my 70-year-olds and ask, do they have a phone? Yes, my daughter bought me one. Is it a smartphone? What's a smartphone? Well, show me. Yes, that's a smartphone. You can have an app on there, and you can actually log in. You're going to need your 8-year-old grandson to get you on there, but you can look at it. And other patients tell me they don't have any computers, any smartphone, no interest in all that. That's okay too. If they're happy to share their information when they need it in the system, they don't need to actually monitor it. We would like them to, or their nominated health, family member who can access that information as well. We would like them to engage them in their own care more, but they don't need to.
The question is, do I need certain medical software to access My Health Record? I'll answer that question in 2 parts. To actually view My Health Record, all you need is a web browser, but you do need to go through all the steps to get registered to access that. And so that's a web-based form now these days, and the process that we're improving. To actually download and upload, you do need a medical software that actually has been tested to be compliant within that, to be able to do that. So you don't need it to view, you need to be registered obviously, but you do need it to be able to upload and download. There is, I'll put in a plug for the on-demand training environment. There is an environment where there's all the different training sites for if you have best practice of medical director, whichever you is, on a website, and that's actually a live environment where you can go in and play as much as you need to, have a go at looking at different bits. So that's that would be a plug, and I'll put in another plug for work we're actually doing with the college about reviewing all our education materials. So we're currently working and we aim to have that all reviewed by the end of August, so that they're all available, have been had the tick and endorsement and reviewed by the college.
Yes, and the online training is very simple to get into, and it has, as I say, simulations of the most common software packages, and it works just like it does in your practice. So I'd certainly commend that, and it's accessible via the digitalhealth.gov.au website.
There's another question going in. It's a great question, Deborah. I've had difficulty registering, getting the whole process started. Why is it so complicated? We've inherited a very complicated system. I would have to agree with you. And this year what we've done is try to simplify it. So the web-based form now is actually goes and checks at the back and gets all those processes checked, but still it's not an easy process. So we'd love to help, so we can get details of how to support you. If you've given it a try, I'm more than happy to actually reach out and walk and get someone specialised to help you through that, because it is still complicated, that registering process, and it's something that we have a target at a date by May when everyone is, the opt-out goes live. We aim to have a much simpler process as well, and that includes doing something different rather than the NASH certification. Will this webinar be available at a later date?
Yeah, so it is being recorded, so we can make it available to, broadly to you at a later point, and we'll provide information on that.
Sorry, can I have a look? The website where you can access the education is onlinetraining.digitalhealth.gov.au.
And best practice is there, Communicare is there, the consumer portal emulation is there, Genie is there, medical director is there, MedTech is there, and ZMed. So hopefully I've
Yes,
just
she said yes.
that that'll be your package.
It's a question for you.
So I'll read that one out from Tony. I and many others are concerned that patient access to their own individual health record and the ability to choose to leave out parts of the history they don't want to share will affect strongly the quality of the record and also the care. Yes, and I think we have to recognise that this is not the entire record. This is a summary record. Today, medical practitioners, pharmacists, hospitals, nurses all deal with uncertainty. We all deal with incomplete information. And this, the My Health Record system isn't going to make that different, but it is going to make access to accurate information easier. But we still have to allow the patients to control the information that's coming towards us. You know, if I gave an example this morning, if the patient's had a termination at the age of 17, you know, that information they're probably not going to want shared. But if I'm writing a referral to an obstetrician, and they're 25, they need to know that there's been a procedure done and it's relevant, but not relevant if I'm sending them down the road for some other care. So in your referrals that you write today, you don't put everything in. You put the relevant information in. And the health summary is meant to have sufficient information really to allow that patient to get a better outcome from the system. Sometimes the patients will want to withhold information, and there's a conversation opportunity to have with them. You know, HIV drugs, hepatitis C drugs, for example, and we recognise that you know we need to recognise that we're reducing uncertainty. We're not eliminating it. The deletion, that's a very good question. If something is deleted by a patient, you know, roll the clock back, less than a fraction of 1% of anything's ever been deleted. So that's the first thing. Secondly, if it was deleted, is there a flag? This is something AMA asked for when I was president. The answer is no, there's not a flag. Because if you see a flag, then the clinicians will likely say, I cannot treat you unless you tell me what has been deleted. If the patient's had a good reason for deleting something, there's a potential there for, well, emotional blackmail. So that's not really deleted. That won't be visible to anyone. You won't ever know that there was a document there. What we said in the PCHR review is that there's a flag set for the author of that document, who already knows what's in the document, so that when the patient interacts with that person again, a conversation can be had. And a clinically curated decision made about is it best to have it not there or best to have it there. So a patient might come back to me and say, look, I deleted that note about the hepatitis C. I didn't want that known. Well, actually, that's probably relevant. You know, you need to have that information on there. And it may be that the information goes back on the next shared health summary. It may be there's an agreement. Well, no, it's not clinically essential to have that information, and you're happy to have it uploaded. It may even be you say, well, if you don't allow sharing of that particular piece of information, it's so serious that you're not going to get a good outcome. At least they have are fully informed about the impact of that decision. Because I think the impact of that decision is real. But I always remind people, we also want to publish the number of documents that are removed. At the moment, it's a fraction of 1%.
Was that one? I think.
I don't think the last one's relevant.
Okay.
Okay, so I think we're concluding the webinar now. So thanks very much for your participation, and we hope it's been a useful and informative experience. Thanks, Monica and Steve, for your time and expertise this morning, and also Sharon, thanks very much for your technical support, and to the college for assisting us with the webinar. So today's session has been recorded and will be made available by WAFA on our website in coming days. A link will be sent to all participants from today's session. If you have any further questions regarding the My Health Record system or would like more information about how to implement within your practice, you can contact the Australian Digital Health Agency or WAFA, and one of our primary health liaisons can come and visit you in your practice. So thank you all for participating, and enjoy the rest of your day.
Thank you for having us.